Okay, I have Dr. Martyn Pitman here with me today. This, I think, is our third interview that we've done for the channel. I can't remember if it's the third or the fourth, but Dr. Martyn Pitman was obstetrician gynecologist, very experienced, and has a lot of views on the Lucy Letby case. So, without further ado, hello to Martyn firstly.
Hi, Chris. Nice to see you again.
Good to see you too. So, we've got pages and pages of questions from viewers for you to respond to. So the viewers are going to see you a lot over the next year, I have no doubt. But before we get into those questions, at the time we're recording this, there's been a lot of news in a very short period of time. So the first thing I'd like to ask you about is the decision of the Crown Prosecution Service, what I personally believe to be the inevitable decision of the Crown Prosecution Service not to progress these further cases against Lucy. So the first thing I'd just like to ask is just your reaction to that news.
Well, the announcement was huge, wasn't it? There was always a sort of spectre or this cloud hanging over. I guess both sides of the equation, the Lucy Letby supporters and the anti Lucy Letby group, really, and that decision about whether to proceed with further charges was pretty monumental, wasn't it? It didn't really surprise me at all when they made the announcement, because I thought both the limited amount of information came out about the cases, but what did come out, particularly the stuff about the tube dislodgement cases from Liverpool, just seemed completely farcical to me. So the nature of the cases, but I thought the timing of it as well, to me, rapidly followed by the possibility of the gross negligence manslaughter against the managers. It just smacked to me, the timing of that was to try and derail the CCRC application. So I wasn't surprised. I guess I was relieved. So it's, and the other stuff that's come out subsequent to it, you just wonder whether the tide is really starting to turn. I guess the next huge thing will be whether or not when the CCRC are going to make their decision, and when and if it's going to be, the case is going to be referred back to the Court of Appeal, and that's out of all of our hands, isn't it, really? Mm. But I guess the positivity that came from our side of the argument will be completely eclipsed when and if that decision is made. But the stuff that's coming out pretty much on a daily basis now, it kind of just makes you wonder what they're waiting for, really. So we'll see. Time will tell. It's going to be an impatient wait, isn't it?
Yeah, yeah. I mean, I'm trying to be patient myself, but I knew it would take a while. I mean, the legal system moves at the speed of tectonic plates, typically. So it's not, you have to, this is the system moving quickly. But like, that's the
Yeah,
thing.
yeah.
People don't, it took 6 months to throw out these CPS cases. That's actually very fast that they actually made the decision that quickly over such a big case with so many infants. And that indicates actually that they knew it couldn't go to court. But whether that was because they've looked at, the professorial level evidence that's come out and decided, wow, that makes us look at this whole case differently, or whether it's more of a political, we know we can't go to court because we know we're going to get annihilated, or if it's a bit of both, I don't know. But the fact they made that decision within 6 months is actually quite a quick turnaround, and that indicates that they knew this case can't go to court. So
I
yeah,
thought it was. There were several bits of it that may have escaped a lot of people's gaze onto it, but I thought it was very informative that the branch of the CPS that looked at this were not the same branch that looked at the whether to escalate the initial
yeah,
cases, from my understanding, and that's, I think, is really interesting, because you then have to question that with that level of scrutiny from the central CPS, had the initial cases have gone through them, would we now be in a very different situation? And I got to wonder if we would.
yeah.
Um,
And I guess another obvious question would be, why didn't they? I mean, get under
yeah,
it's not like it's not a parking offence, is it? I mean, why didn't it go through the central body the first time?
Mm, mm. And again, the Cheshire Police's response to it, rather than taking it on the chin and accepting it, to go back at the CPS and say, well, we think they made a mistake. We thought we'd hit the bar. Well, that's not your assessment. You do your investigation, and when you think you've got enough, you refer it up. And if the CPS say there isn't, then that's it. But to go on record and to go out to the national press to say we don't agree with it, I thought was astonishing. But is that the sign of an organisation that's now getting rattled and is getting worried about where this is going?
I think the short answer is yes.
Yeah.
I just think the answer is simply yes.
Yeah.
I think in their defence, I don't say too much to defend them, but if you had presided over something like this, that there's kind of a compelling psychological need to believe that you're right, because the other reality is not palatable. I mean, who would want to send someone to prison and destroy them psychologically, mentally, emotionally, every possible way, and be wrong? No one would want to be wrong. So it's ironic that they keep using this phrase "thinking the unthinkable," because they were all too ready to think the unthinkable, that Lucy might be guilty, but actually the unthinkable from their perspective is that they're wrong. And they know deep down, I'm sure deep down, Paul Hughes, like Daniel Stoney has been another prominent police officer, Nicola Evans, Nigel Wenham. I'm sure, I mean, Wenham's, I think, is retired, but I'm sure certainly those that are active in Cheshire Police now, I'm sure deep down they know that they're wrong. Because how could you not? How could you not? Looking at the level of response and the caliber of the response, and then the lack of anyone backing you up. How could you believe otherwise? So deep down, they know they're wrong, and
that's another question, isn't it? That had they have decided the other way and gone with it, who would they have got as experts?
Yeah,
because they haven't exactly been it's not exactly been a tsunami wave, have there, of experts from any specialty that can't say, oh, hold on a second, yeah, I agree with Dowie Evans, or they've been. I think there was one person this week, wasn't there, a consultant from Norwich who's come out and
he's run away now.
Oh, really?
Yeah, I won't tell you why, but I know why. So.
Oh, right. Okay,
yeah.
That's interesting. But that's the first one that's appeared on social media to say, oh yeah, and that was agreeing with
I don't think he'll be commenting again.
Huh. Yeah, and that was agreeing with the our Antipodean
our expert
input, wasn't it?
Down under. I think it's just essentially made a bit of a flippant comment, and I don't think we'll be hearing from him again. But I think with regard to the court situation, I think even if you sort of agreed with the prosecution, which seems highly unlikely, from a reputational perspective, would you put yourself in court at this point? I just can't see anyone. And I'm sure that was a primary consideration for the CPS. I'm sure one of the primary considerations was we're going to look at the experts. It's more than an inverse of the original court case, because there's so many. It's just going to be a slaughter, because there's going to be dozens of experts against our one we might have if we're lucky. And it could only have made the Crown Prosecution Service look bad if this has gone to court. So yeah. And then also, let's just briefly talk about the Netflix trailer. So again, I've said this in previous videos, or in other videos. At the time we're recording this video, we haven't seen the Netflix documentary. This is probably going to go out after the Netflix documentary, which we haven't seen at this point in time. So we're just responding to the trailer that we have seen. So what was your thoughts on that?
Mixed, really. I mean, the documentaries that have preceded it have been a mixed bag, really, haven't they? So, I guess I'm feeling the same about it as I felt about the last few that have come out, in that you never quite know what slant they're going to put on it. Are they going to be completely impartial and give both sides of the story? Which I think the closest one that fits that description perhaps was the last one, the Channel 4 one that was also in the cinemas. Is it going to be journalistically accurate? In which case, the one that had the most views is 18 million hits now. The ITV one. That was pretty positively received, judging by the viewership of it. The trailer itself, I thought, was pretty shocking, really. I mean, it was clearly designed and structured to make maximum impact. Bits of videos that haven't been seen by the public. Well, they haven't been seen because I think most members of the public would think that they shouldn't have been seen. How it can be appropriate for a police force to, and I completely get they wear body cameras and they're on, but how it can be appropriate to distribute. How did they decide? Was it a bidding war between TV production companies? I've got no idea, but to take images of somebody being arrested in their bed and then being distraught as they say goodbye to their pets, I'm not really sure who that's going to benefit, really. So I think most members of the public, even if they're sitting on the fence, would think, oh, hold on, this is a bit invasive. This is, and it also, from the police's perspective, it raises questions, I think, about when you find you find yourself in a police station and you're going to be questioned either under caution or under oath, and they say, "Oh, is it okay if we record this?" Because I think if people realise that presumably without consent, those videos could be given to a TV production company is pretty scary, really. So I just hope that it's going to be balanced. It's going to show both sides of it, and it'll be in a way like maybe like the Channel 4 one, where it was sort of thought-provoking and this is where we are. But I was pretty shocked, really, with the videos. I can't get my head around how that is appropriate. And there's been loads of stuff on social media about her being handcuffed and why they had to go around first thing in the morning and arrest her. And I saw when you'd been doing Steve Watts when he gave his opinion on that, and she was arrested for multiple murders. Yeah, I get that, but what actual level of risk was she, and was that all done for drama and for maximum psychological input for her? So I suspect those bits of the videos will be elaborated on in the actual documentary. So I'll certainly be sitting down to watch that, and we'll see how that goes. Maybe I presume that's going to be the last one for the time being. Now I don't think any of us have heard about any more coming out. So we'll see.
Yeah,
and also see what reaction it provokes.
Yes, I guess we'll know soon.
What did you think of it, Chris?
What did I think of it? I found it pretty upsetting. I mean, my first feeling, honestly, when I watched it was, I just can't wait for all this to be over. I'll be here for as long as it's required, but I just thought, this is just awful. I mean, it's just, I try not to get emotionally involved because, I need to focus on the facts and focus on what I'm doing. But of course, it's very difficult not to get emotionally involved when you see a young woman who's put in those circumstances, when obviously I'm 99.999% certain that she's innocent. The only reason I don't say 100% is that I don't wish to make claims that are untrue. I can't be 100% certain. I wasn't there at the time. But as soon as I saw that blue note that I've highlighted many times previously, where she said, "There's obviously no evidence against me," I knew that she was innocent, because it already looked very strongly to me by that point that she was innocent. And then there's just no other justification for that. No, it doesn't make any sense in any other context. So I just generally found it quite upsetting to see her. I haven't got cats, so I didn't get. I know some people found that quite triggering and upsetting to see her with a cat, but I know for me, if I had to go to prison, that the hardest thing for me would just be saying goodbye to my dog and not being around my dog. It'd be so hard. That would destroy me.
The bit that got me as a parent as well, because I've got two grown up daughters. The bit that got me as a parent was the and I assume it was when she turned back and said, "Oh, just shut the door, don't look," and it was so in the height of her upset about it all, I assume that was protecting her parents. So not wanting them to see her being handcuffed and put in the back of a car.
Yeah,
and it's what so many thoughts about the collateral damage of what has happened to a certain extent. Whether or not she's innocent or guilty. It's neither of my daughters went into healthcare. I was quite pleased about, but I think as any parent, if you've got a daughter who is a nurse or affiliated healthcare worker who works on a neonatal unit or an ITU, that there has to be a degree of fear now about could they end up in a similar position if you're working in a high risk specialty and you've had a bad run and been present when a few patients have died. And I think it must be anxiety provoking for parents, but also I'm absolutely certain. I think there is some evidence that applications for nursing posts has decreased as a result of this now, particularly for things like NICU and ITU. And I get that. I completely get that, because who the hell would want to put themselves in this position, particularly if she gets these honour races let out, because but for the grace of God is one of the things. The thing that happened with me, that there weren't many positive points about what happened to me, but one of the big ones was that I didn't give the trust any ability to go for me clinically, because my even chief executive's own words until right at the end were that my clinical standards were exemplary. But had I have done, if I'd have had a series of suboptimal outcomes, it does make you wonder how far they would have gone with that nowadays. With a little tinkle to the police force of happy. There was nothing. I was very proud of the clinical outcomes that I got. But if that had been different, you just never know now. And that's one of the things that really scares me about what Thurl was going to come up with, because there are rumours that one of her recommendations is earlier involvement with the police force and that's, oh my God, that is terrifying.
It's just incredibly dangerous.
Absolutely the wrong people to get involved early, as this is shown. So the collateral damage of this is going to be, it's going to be profound, I think.
I mean, one of the things that I was going to mention to this gentleman who made the flippant comment on social media, he made some ridiculous, in my view, ridiculous remark about the tubes falling out. So I was just going to say I mean, I don't think he'll be speaking with me, but I was going to say to him, okay, let me ask you a question. Let's say you worked in a hospital and a couple of tubes fell out, and they looked in the rotors and they said, oh, Dr. Clark was around quite a bit. And then it went to the police, then the police sent you to court, then the court sent you to prison. How would you feel about that? Would you think that was fair? Because that's what you're suggesting. Do you understand that? Anyway, I don't think I'm going to hear from him again. So, but yeah, like, people are so flippant about these things. Imagine what it's like. I mean, I just, the in the Netflix, they barge into a bedroom at 6 o'clock in the morning. She's even just if anyone came into your bedroom that you weren't expecting to be there, it's terrifying. I mean, the first thing I would say to them is get out of my bedroom, but I wouldn't put it up politely. I won't say exactly what I would say to them.
The only plus point about that, of course, is that she has shot all this pajama gate nonsense in the foot, isn't it? What she wearing. But it begs the question, if Lucy Letby had been wearing, another sort of nightwear, would they still put the video out? It's it's just astonishing. It's just astonishing. So yeah. So
what if she was in bed with someone else? I mean, I know she's in her parents' house, and I guess it's not the best time to get into a relationship, but what if she was in bed with someone else? What if they were,
I guess there'd been a privacy issue then for the other person, wouldn't there?
They wouldn't have been able.
It's astounding. I think that let's see how the documentary pans out. But I think that there needs to be some serious questions asked about how the production company were allowed to get those videos, and was it a gentleman's agreement, or was it a bidding thing? Was there any money involved?
I mean, the fact is, it shouldn't have happened in the first place, because she's not a flight risk. She's not dangerous.
Yeah.
You don't need to stand over with a SWAT team. Like, what's she going to do? Like, she doesn't look like she could overpower me, let alone she's no risk at all. It's absolutely ludicrous. I mean, that just reflects badly on the police. But anyway, we'll see what comes out of the actual
documentary. It's not long to wait. It's next week, isn't it?
Yeah, at the time we're recording this, it's a week away. So obviously I'm good, but you will have already seen my response probably by the time we put this out. So let's crack on with some viewers'
Go for it.
questions.
Go for it.
So this one is standing out to me immediately, because I know that Maury's gonna. I can't say again. I can't say how I know this, but I know that Maury's going to come out on this. So, do you have any comment on the £60 billion NHS crisis and the role that maternity has played in this?
Yeah, plenty of comments really. I think it's. I mean, for those viewing this who don't know what this is all about, the situation we're in now with UK maternity servicing, you'd have to live in a vacuum really, not to know what's been going on. And that's partly why I did what I did back in 2019. That I was concerned about standards of care and avoidable bad outcomes to mums and babies, and not just the personal damage and family damage that results in, but also the collateral damage, the litigation costs that was going to cost the taxpayer. The situation where we are with maternity care at the moment for the last, I think it's 2, if not 3 years, is that the taxpayer, so via the government, basically it's a bit like an insurance policy. So there is a huge pot of money that the government sits on, and that is there to pay litigation payments across the NHS, and trusts identical to really with house insurance or car insurance. The trust pays a premium, and that contributes to it. And the situation where we are now with maternity is that the government is paying more to settle successful litigation payments in maternity than it is to provide the annual maternity budget for a year. Now, just think about that. So the billions that the government, the taxpayer basically, is paying to look after mums and babies has now been overtaken by the amount every year that is paid out to, it's the 2 groups, isn't it? It's the parents or patients that have had bad outcomes and are found to have got into the situation where they warrant compensation, but also momentously huge payments that are paid out to medical legal solicitors and barristers and lawyers.
I mean, essentially, half of your tax money is going to that because that's what it's paid from.
Yeah. So it is lamentable. It is embarrassing, and it has to be addressed. And there's various different schools of thought about how that could be addressed and how the payments could be reduced. But the fundamental thing is we need to be adopting standards of care that mean fewer people, fewer babies, fewer mums get damaged. So off the back of that, now we have got a whole series of maternity reviews or inquiries that have been undertaken in chronological order. You've got Morecambe Bay, you've got Shrewsbury and Telford, which is the first one that Donna Rockington got involved with. Then there was East Kent. And the tragedy with all of these is that they were kicked off, not by the health service, not by the hospitals. Each of them, they were kicked off by parents who basically wouldn't let go, who kept pushing and successfully. And the first one being James Titcombe in Morecambe Bay, that Jeremy Hunt agreed that for that inquiry to be honest. And they're all pretty much. And then if you move on from that, so we've now got Nottingham, which is going to be huge. And now we've got Leeds, we've got Oxford, and now Wes Streeting has appointed Baroness Amos to conduct a review. So not a public inquiry, it's not statutory. So she's looking at, I think there are 14 units that are going to be looked at in a very rapid fashion. So you have to question how much depth that's going to be done in. And to come out with conclusions, recommendations. Now, obviously I've got a vested interest in it, so I've looked at all of the previous maternity reviews and inquiries, and they pretty much come out with exactly the same. It's the same deficiencies, the same problems. So what it basically needs is for somebody to actually act on the recommendations that come out of the previous ones. And I suspect we're going to find with the huge 4.5 years that the Nottingham investigation would have taken Donna Rockington and her team, I suspect all they're going to find is exactly the same problems, but on a much greater scale. And the information that's come out of the Amos review so far is that there are currently over 700 recommendations. Well, that's just not going to work. I mean, it's just so So I think it is lamentable. You know, I tried my best to do what I could locally to make a difference, and look what happened. You know, I think it's got to happen. It is just embarrassing, and pretty much every day that goes by now, you see something else in the papers or the press. You know, there's a focus at the moment. There've been some home birth tragedies, and I just read it, and there's another one yesterday where a poor baby was killed during a forceps delivery that suffered spinal fractures and skull fractures, and I just shake my head in disbelief. You know, this is the UK in the 21st century, and these things are repeatedly happening, and it's the same things time and time and time again. So it's got to change. It's a question of how it's changed and who's going to have the ability and the power to force it through, really. And I think there needs accountability on it as well, because part of the problem with the previous reviews is that recommendations have been made and nothing's really changed, and nobody's held accountable to it. So I think there's pressure at the moment from a group trying to get somebody sort of officially appointed into that role, so that there is accountability at a government level for it, which I think would be very positive. But it needs change. It needs radical change, and it's costing an extortionate amount of money. I mean, that figure that you quoted, imagine if that, even if half of that could be devoted towards patient care and waiting lists and training in maternity. And it's but it's not, you know, I've been quite outspoken about my view on it, and the NHS is a bottomless pit as far as money is concerned. It's a big black hole, and as far as maternity is concerned, I don't think it is as simple as throwing money at it. And I use a very simple explanation for that. If you look at the units in the country that are never involved with any of the scandals, and they're providing exemplary levels of safe care to their patients, is there any evidence that they're doing that because they're paid more money? No, not at all. Not at all. So to my mind, that proves that the units that are failing, it's not because they've got less money, it's because the system is wrong. There is a cultural problem, there's an ethos problem, there's a management problem. Something is wrong.
Can it be a knowledge and skills gap possibly as well? Can that contribute?
Potentially, and I think one of the areas that I work really hard on locally here when I was appointed, because I had a sort of a career-long interest in it, is how babies are monitored. You know, in labour, babies are either monitored, you're just listening into the baby's heart rate using a Doppler, or they're electronically monitored. And I specialised in the latter, in the interpretation of electronic heart rate monitoring. And it's far from perfect. It's far, but it's the best we've got, and it's going to stay with us for the foreseeable future. But it's acutely depressing, the number of babies that are still being damaged, or worse, because, you know, pathologically obvious fetal heart rate trace recordings are missed or ignored or not acted upon or not escalated. And that's just, and there have been moves over the last decade, to be fair. Baby Lifeline, a group that have been pushing far better, far more detailed interpretation of fetal heart rate recordings to try and reduce this, but it's still happening. So yeah, without a doubt, education, silo working's got to change. You know, with part of the problem, I think, and I think it was part of my vulnerability, was I think maternity is unique in that you have two very, very closely, intimately allied professions, so obstetricians and midwives, who, if you're going to be most effective in what you're doing, need to work incredibly cooperatively. And we were very lucky at Winchester in that predominantly that was the case. The problem has developed, though, and continues clearly in some units, and what Donna Rockenden is finding, where they are completely siloed, and there's almost a battle between the two professions. So you've got the midwives trying to keep everything normal and low risk, and then you've got the big nasty obstetricians who are wanting to do cesarean sections and forceps deliveries on everybody, and in a way, never the twain shall meet. And that you know, it was happening in the normalisation agenda. I believe it was one of the most negative things in the last 20 years that developed, where there was a huge pressure centrally to reduce costs, to focus on getting as many babies out as they possibly could vaginally to reduce cesarean section rates. At one point, potentially with the imposition of financial penalties on obstetric units that had high cesarean section rates. And that, I think, was undoubtedly detrimental to patient care. And I pride myself, and I'm very proud that I refused to go down that route from throughout my career, but particularly at the consultant level. And I always saw that, again, in the UK in the 20th and then 21st century, I thought that parents had a right to choose how and where they had their babies, and that included with informed support and approval of maternal request cesarean sections. And I think that proved to be my initial vulnerability, because it was in the face of what was happening nationally at the time, and it was when our two trusts merged. The unit we merged with in Basingstoke had a completely opposite view on that, and they were very anti cesarean section. So I think, and that put me in a position of vulnerability with the senior midwifery management. And then I think I won't go through what happened after that, but now I think Donna Ocken does what she's found and what she's instituted. Pretty much one of the juniors that I spent some time working with a few years ago, when the first Donna Ockenden report came out, contacted me and said, "Crikey, that her report reads like the epitaph to your career," because she basically was saying every single thing that I've been saying for 20 years. And of course, I was criticised in my trust for, and it was completely brutally unfair on me, as anybody who worked with me would contest. I think I was almost individually held responsible for our unit having a higher cesarean section rate than our neighbours. The joke of that now is, of course, that since I left, the cesarean section rates have almost doubled, which proves the point, really. So yeah, huge amounts of money are being wasted, which could and should be diverted towards patient care.
I guess like I can and would add to that is that this Lucy Letby case is ultimately about patient safety. It's ultimately about patient care and patient safety. And obviously, if we can, if the NHS can improve the quality of maternity care, then it reduces the possibility that something like this will happen again. It's not the only way that this should be reduced. There should be legal changes, and hopefully there's going to be a lot more awareness when Lucy's exonerated. But definitely patient safety and patient care is at the heart of it as well. So
yeah, and of course, the thing I said all the way along, Chris, I think the other sessions that we've had, it's come up in each one, but my concern with the Countess of Chester and the Lucy Letby indictment cases is the, and I know you agree with this, it's the abject paucity of anybody looking at the maternity histories of the cases. And it's very, very unusual in my experience, having been in the business for.
Well, I mean, we know why this happened now. So, because Dr. Evans said, "Oh, I don't need to see it."
Yeah, no, absolutely. But it's very, very unusual in my experience, having worked in numerous hospitals. You normally find the standard of neonatal care matches the standard of maternity care. So if we're hypothesising, which it appears clear, that there was a deficient standard of patient standard and safety of patient care in the neonatal unit in Chester, then I would be absolutely astounded if there was. Well, there's plenty of evidence that there wasn't, but if it would be very, very surprising, in my opinion, if there was an exemplary standard of maternity and obstetric care in that unit. And I think that will be proven when Mark MacDonald's group of 4 of the most eminent obstetricians in the UK comment on what's already available, because I'm being criticised for making comments without having access to the full notes. You don't actually need to. There's enough out in the public domain as an obstetrician to know that what happened with these cases was very very questionable. Particularly if you think about baby D, when even the trust in Chester accepted that the management of that case was negligently deficient, which is impossible to argue. But I think once the maternity notes are released, which presumably they will at some point, I think that's going to be further torpedoes going towards dear old Dowie's theories.
Yeah, absolutely. So I want to ask you a question about the triplets in the Lucy Letby case. And I'll read the whole question for you and then you can respond. So it says, Dr. Pitman explained that subcapsular hematoma is vanishingly rare during cesarean, but given the circumstances of the extraction with the mother feeling pain during the procedure, could that have put the surgeon under pressure to extract the babies as quickly as possible? I think it's significant that both baby P and baby O required a little oxygen. Baby P had a small subcapsular hematoma and baby O a larger subcapsular hematoma. Do these circumstances of the delivery and the fact that two of the triplets had a subcapsular hematoma make traction injury at birth a likely possibility, as I believe is the opinion of the expert panel? I find that the parents have important things to say about the care they received. I'd be interested to know what Dr. Pitman thinks about how the operation was handled based on the mother's testimony. So let's talk about, firstly, the circumstance of the extraction, putting the surgeon under pressure to extract the babies as quickly as possible. What do you think about that?
As a blanket comment about everything, that's a pretty astute question. As a blanket comment, pretty much all of that would be very, very easy to answer with access to the notes, with access to the anaesthetic records, and with access to the log in theatre. So going through those in order. So access to maternity notes, you're then going to be able to see the precise details about the cesarean section, and also, what was the what was the reason for the need for the rapidity of the delivery? Was it because of the twin-to-twin transfusion, which I kind of get? And I think I went on record when we discussed elements about this case before, Chris, that what you don't want as any surgeon, to a certain extent, however experienced you are, having pressure on you to do something quickly in my experience, is never a positive thing. You should know, particularly as a senior obstetrician, when you're going in to do a case, that there is a degree of urgency in what you're going to do. But having an external pressure that you've got to do something quick, all that does is it kicks out your stress hormones, your adrenaline and noradrenaline and cortisol, and it makes you rush. And to be brutally honest, if I was having an operation, I would far rather it was done by a safe and effective surgeon than a quick one. Because if you quit, you're cutting corners, you're more likely to traumatize tissues, and in maternity and obstetrics doing cesarean, that almost invariably equates to tears and bleeding, particularly in a potentially tricky case as this would be, because the uterus is so huge with 3 babies, 3 placentas, or 2 placentas, however many this had, and three swimming pools of amniotic fluid. The uterus is huge. So, the glamorous bit of the procedure is delivering the 3 babies, cut and clamping the cords. Then your work starts as the obstetrician, really, which is getting the placentas out, making sure everything's out, and then that's when the speed comes in, because then you've got to get that uterus to contract. And the reason for that is that you've got all of the big blood vessels that are feeding into the placental bed to nourish, oxygenate the babies, and all of those will bleed. So you want the uterus to contract down, and the anaesthetist will be throwing lots of drugs and things at the mum to make that happen. But a lot of that is down to surgical technique. So you don't want to rush, you don't want to cause tears that go down into the cervix and into the vagina, because that just causes more bleeding and then increases the time and then increases the risk to the mother. So from the first part of that question was that there's an account of the mum feeling pain, and would that have put pressure on the surgeon? It shouldn't. But again, it's again, I remember discussing this the last time we discussed this case. I have got no idea who did that cesarean. The dad's recounting of it was that it was a female and she looked very young. Now, I don't know, it's possible there may be a young female obstetric consultant there. My concern is that it wasn't the consultant who did it. And if that's the case, I think that is highly questionable. In most units, certainly any hospital that I've worked in, and that's ranging from small district general hospitals up to huge teaching hospitals, I can never remember a triplet cesarean section being done either by either by a consultant or by an experienced junior with a consultant assisting the other side of the operating table, or if you're in a teaching hospital where there's a senior registrar who's just about to be a consultant, and the consultants in the in the labour ward. But so how experienced was the person doing the cesarean? Because it's too late if you've got to call somebody in who's in a clinic to give you a hand. From the pain perspective, that's an anaesthetic issue. It's a regional anaesthesia would have been used for this, so probably that would have been what's called a spinal anaesthetic. So that's a bit like an epidural, but you don't feed a catheter in, so it's a one-off injection. So you use a syringe and a needle, you find the gap between the two vertebrae, and you pop the needle in, and it's a defined dose of a high density anaesthetic agent, and then you take the needle out when you're in the right place, lay the mum down, and almost by the time you've laid the mum down, there's enough analgesia to put the catheter in, and then by the time the obs guys have scrubbed, there's then appropriate analgesia to do the operation. Sometimes they use what are called combined spinal epidurals. So you do a spinal, and then you feed a little catheter into the epidural space, and then you use an infusion. Normally, if you're expecting the procedure to be protracted or drawn out, and I don't think from what I could glean from this case that was thought to be the case. So if a mum, so the anaesthetist tests the efficacy of the anaesthetic before the obstetricians are allowed to start or to sterilise, and they do that either by pinching or by using a freezing cold spray, because the nerves that take pain sensation are the same nerves that take temperature sensation. So they use a freezing cold spray, and they find the level in the mum's skin where they lose temperature sensation, and that will tell them whether or not there's an appropriate level of analgesia to do cesarean section. So that presumably would have been done. They then sterilise, pop the drapes on, make sure the paediatricians are ready, and then they start the procedure. If the mum is then feeling pain, there's a limited amount the anaesthetist can do. They can give intravenous opiates to the mum, but then some of that will cross the placentas to the babies, which isn't ideal. Ultimately, if the mum can't tolerate it, then you have no option but to do a general anaesthetic. But that's not ideal at all, particularly in a mum with triplets. So, but if the obstetricians have started and they're getting, I'm feeling that really hurts, or if the mum starts crying, you imagine the scenario as a relatively junior surgeon, if you've got this going on, and you're conscious the dad's there, and the dad's making comments, and the anaesthetist is getting stressed. It's not a nice place to be, really. So I can see how that could have affected the process of the cesarean. And then, of course, the other bits that came out from the parental account of the cesarean section was the speed of the delivery. We've covered that already. 3 babies to get out. I don't know. It's impossible to know without looking at the records. There will be a record somewhere which has got what time the knife to skin was, what time the first baby was delivered, what time the second baby was delivered, what time the third baby was delivered, what time the placentas were delivered, and then what time the procedure ended. And then any important aspects that happened in between will be noted either on the anaesthetic record or on the theatre record. So the timings will be there. So this debate about how rapidly the baby's delivered will be very, very easy to answer. As far as the shearing forces on the babies are concerned, again, it's difficult to know because nobody seems to have spoken to the person that did the delivery. I can understand if it was a tricky delivery. Normally, triplets are lovely to deliver because they're quite small. The uterus is massive. I've never touched wood while we're doing anymore, but I never had a bad experience delivering twins or triplets. But again, if you've got an inexperienced surgeon and they're rushing, the shearing forces would probably be more relevant if you were doing a breech extraction. So if the baby was bottom down, you make the hole in the uterus, and if the baby's needed to be pulled out backwards, if you like, breech, then there's sort of a rotational procedure that you do on the babies to ease the delivery. I can see theoretically how that could have caused the sort of shearing forces that Shuli was describing that could then put that shearing force through on the ligaments of the liver to cause the hematoma. But again, we discussed it before. I never saw it in 30 years of obstetrics. Jim Thornton's never seen it in 40 years of obstetrics. So now that doesn't mean it hasn't happened, but it means that neither have had or seen or heard of subcapsular hematomas that were big enough to cause symptoms to the baby that caused a problem. that needed surgery, for instance, or as in these cases where they ruptured and the baby died as a consequence. So I can see how it could happen. I personally think there are other explanations that may be more relevant. And I can't remember who it was. It was a female pathologist I remember seeing interviewed in one of the first documentaries, who said that in her opinion it was more likely that the subcapital hematomas were due to a combination of prematurity and hypoxia. And she said, subclinical occurrences of these, she said, were quite common. So I think that's potentially more likely that this bruise formed, the baby was stable, then started to decompensate. As the bruise got bigger and the baby lost more blood from its intravascular compartment, that was consistent with the heart rate of the baby going up, which was certainly there for baby O. And then the capsule either spontaneously broke, which you then lose the tamponade effect of that, releasing the blood into the peritoneum, and then the baby crashed. Or the contentious bit is whether or not the needling procedure helped that along. So did the needle puncture the membrane over the hematoma that then caused it to leak? But either way, the way that baby responded, the huge red flag question over baby O's resuscitation is, of course, why no blood was given. Every neonatal unit should have O negative blood there specifically for this situation. And of course, you've got on the top of that, you've got the 2 blood results, which we talked about before, which apparently the consultant who was there knew about, because they recorded on a piece of paper with his hand. So he knew that a huge drop, some of which would have been dilutional because of the amount of fluid they were pouring into the baby to resuscitate, but not all of it. But there was never any decision to give blood. And what's even more inexplicable in my mind is why the resus was abandoned without giving blood. Because if a baby has arrested and is dying through loss of blood, the only thing that's going to turn that around is giving blood back. And the other things, of course, that in the parental recollection of that cesarean was this thing about there being a big gush of fluid and blood that went over the drape and hit the wall in the side of it. Well, that's astonishing. I mean, I can't get my head around that. There can be blood that spills, but for it to go right over the drape, which is basically stopping the mum and dad from seeing what you're doing, to then hit the wall. I mean, I don't know how big the theatre is, but that's incredible, and that does make you wonder if there was a real rush to go in. But again, looking at the notes, speaking to whoever did the delivery, the experience of the person doing the delivery would answer all of these questions. Does that cover all of that question?
I think that's a brilliant answer. Thank you. Yeah, I don't think we need to go back to anything. That's very good. So let's look at. I've got a question here on child C. Please expand on child C, the baby that had severe intrauterine growth restriction. It was only 800 grams, very much smaller than would usually be expected, of course. Please discuss the implications growth restriction has on a neonate and what conditions that it can make the baby especially prone to.
Okay. Yeah, it's a question of extremes, Chris, and I think this flies in the face of Dowie Evans's claim that all of these babies were well, stable, and not really needing any input. So just to put this in perspective again for the non-medical, non-obstetric, non-neonatal people in the audience, this baby was a singleton baby, so a single baby, and the growth restriction was extremely concerning in this baby for 2 reasons. One, because it was profound, and for those of you that aren't sort of in the field, the figures that Chris just gave you probably may not mean very much, but this baby was minute. So this baby was about half its expected birth weight given its gestation. So this is a baby, to put it in perspective, that would very easily fit in the palm of one hand.
So obviously it's very premature, so it's half of its expected birth weight. How proportionately big would it be compared to a normal gestation infant?
Well, the average size for a baby to be delivered at term at about its due date is 3.5 kilos.
So
800 grams. That's minute. The other thing that is worth bearing in mind with this baby is the gestation at which this process started as well, because this baby, the concern about this baby was picked up even before the mother had their anomaly scans. I think it was about 17, 18 weeks the first concern arose. So if you think about how a pregnancy is managed, the vast majority of mums will get a scan in the first trimester of the pregnancy to confirm they're pregnant, whether it's the dates of the pregnancies, how many weeks they are, how many they're carrying, basically, and to check they haven't had a miscarriage. So they get a scan between 12 and 14 weeks. The next scan they get is around between 19 and 21 weeks, which is the main sort of structural check of the baby to make sure that the baby's progressing okay, everything's in the right place. The other thing is you're looking for abnormalities that may suggest that the baby's got a genetic syndrome. So the other reason that scan is done then is done at a gestation, where if you pick up structural problems that may indicate a chromosomal problem, you've legally got enough time to do an invasive test if the parents want it, and to potentially terminate the pregnancy if you pick up a genetic syndrome which is sort of incompatible with life or of a concern. And the theoretical threshold of that is 24 weeks. So this baby had problems that predated that scan. So I presume the mum must have had some sort of problem, which meant she had an additional scan, which showed even at 17 weeks there were problems. And then what happened later on was the baby was found to, when you pick up a mum and a baby that've got a problem like this, you end up with shed loads of scans throughout the pregnancy to basically check how the baby is doing, check whether the baby's continuing to grow, check the fluid volume around the baby, because you normally find if a baby stops growing, the fluid, which is predominantly the baby's urine, the horrible thing to discuss, but in utero, the waters of the baby are the baby's urine, and that urine, that fluid sort of bathes the baby, but the baby also breathes the fluid in, which is critical for its lung development. And also for the limb development, because if there's very little fluid around the baby gets contractures, so the legs and arms don't bend properly. And the other thing that on those scans, probably the mum would have had scans fortnightly. The obstetricians, the fetal medicine people would have been to have looked at the blood flow, and this is where it gets complicated, the blood flow between the baby and the placenta, but also the blood flow in the baby. So I won't go into that in too much detail, but the things they would have looked at would have been between the baby and the placenta, which is a little bit like the best analogy I used to use with my patients is if you buy an old house and you've got really awfully clogged up radiators and you've got a boiler that the pump in the boiler isn't working very effectively. However good the boiler is working, if the tubes going out to the radiators are bunged up, then you're never going to get a hot house. And that's probably, that sounds like what would happen with this baby, because you look at the blood flow using ultrasound between the baby and the placenta. And in a baby that's doing really well, you always have what's called positive end diastolic flow. So this is where it gets a bit physics and complicated. So when the baby's heart pumps, the blood will be moving away from the baby to the placenta. But in a normal plumbing situation, if you like, when the heart isn't pumping, the blood continues to move away from the baby. So there's a middle ground which is called absent end diastolic flow. So that means when the heart is pumping, the blood goes from the baby to the placenta, but when the heart isn't pumping, it's static. This baby had what's called reversed end diastolic flow. So that's the worst prognostic sign of umbilical Dopplers. And that means when the heart is pumping, the blood goes away from the baby, often under high pressure, but then when the heart isn't pumping, it backs back to the baby, so it goes the wrong way. And that can then lead to heart failure and all sorts of complications for the baby. So that is, when you start to see that on a fetal ultrasound scan, you know that you haven't got very long left before that baby's going to need to be delivered. And that finding normally goes hand in hand with finding significant abnormalities in what we were just discussing before in the heart rate monitoring of the baby. So you'll start to see pathological changes on that as well. It's normally a combination of those two that will make the obstetricians, what I did for 20 years, will say, okay, the baby needs to be delivered. So you then time your steroid administration and then you plan the delivery. The other form of Dopplers that they use is even more clever, which is where you can actually look at the blood flow in the baby. And for that, you use the same kit, so you use an ultrasound machine, and you look at normally the blood flow in what's in the middle cerebral artery in the baby's brain, which is about a millimeter across. So there's a little circle of blood vessels in the baby's brain, and the middle cerebral artery is a branch off of that. And you look at the blood flow in that, and that enables you to see whether or not the physiology of the baby is protecting itself. So if a baby's getting into trouble, nature is very, very clever, and it protects the baby. So the baby's homeostatic physiology protects it. So it basically decides, well, look, I can survive without moving, and I can survive without blood going to my muscles, but I can't survive without blood going to my brain and my central organs. And you can detect that using ultrasound. So you then detect a sort of a hyperdynamic circulation in the baby's brain, where you can see, okay, this baby's starting to decompensate. So it was a combination of those things, I'm assuming, with this baby that made the obstetricians decide, okay, enough is enough. The critical thing, though, is the earlier that process occurs, depending on what's causing it, the more likely that baby is to have problems postnatally. And I understand from, I think it was documentation that came out of Thirlwell, that the fetal medicine consultant who's looking after this lady was pessimistic about this baby's chances, because this growth restriction happened so early and in such a profound nature, that he was very guarded about the likelihood of this baby doing well and potentially even surviving. And the reason for that is that until the baby is delivered, it's impossible to tell what potential damage has been done to the baby's organs. And particularly you think about things like could the bowel have been injured? So with this redistribution of the blood supply, could it be that not enough blood has got through to the baby's bowels, and the bowel can be ischemic? An ischemic bowel then leads on to things like NEC, or necrotizing enterocolitis, when babies are born, which can lead to bowel obstruction, and with that you then get the bilious vomiting, which was seen in a few of these babies. So this baby, despite what Dowie Evans claimed, this baby was gonna, at the best, was gonna have a very, very rocky postnatal ride, and at worst, was going to have complications that may well have led to either needing surgery, perhaps, or worse, which is what happened. But for this baby, it sounds, from what we know, again, I haven't seen all the notes before the trolls start getting at me, but it sounds to me as if this baby was likely to have a really stormy postnatal course, if not worse. And again, it's a bit like a lot of this, which is one of my real concerns about Dowie Evans, is his inability to look at the bigger picture. And any area of medicine, you have a list of differential diagnoses, and it seems to me that Dowie Evans forgot all the obvious stuff, which is what we've just discussed, and always went for the least obvious one. The injecting air into the stomachs or into the vasculature, or the other things that he dreamed up. And I just, you've got to be pragmatic in medicine. It's very, very rare, in my experience, that you can say, oh, categorically, this was this diagnosis. It might have been, but you've got to be broad-minded enough to say, yeah, but it's, that's a possibility. That's the last thing on my list of differentials, as they're called. And but these are far more likely. And with this baby, like many of the others, as Xu Li found, that why do you ignore the things that are shouting at you as the likely cause, and going for the one right at the bottom? I was at medical school, and in my group in medical school, there's a guy. He's one of the brightest guys I've ever known, but he. I think it's partly because he was so bright, he could remember lists almost like a photographic memory. And whenever you were in an exam situation, in a viva, if he was asked what do you think the diet, he would always go for the most obscure minutiae, I think, at the bottom. And he always used to hack off our lecturers because he was so bright, but he would always go for the least likely thing. And maybe he became a Dowie Evans in his clinical life, whereas the rest of us who weren't quite so bright were able to remember the far more likely thing. Right. So I think baby C, but a very, very high risk clinical situation. that I don't think really came out. I don't think in the trial or after.
Yeah, yeah, absolutely. Thank you very much. So I can almost answer one of these questions myself, but
Give me a break.
well, I think we'd like to hear your more informed opinion, nevertheless. But I think I can still answer some of this. So, are there enforced protocols for cleanliness and hygiene in NHS obstetric maternity units? Are these sufficient, and what red flags have you noted about the hygiene practice in the Council Chester maternity unit, including from the parents' testimonies? So, all I will say to begin is when you've got nappies stuck to the ceiling to prevent sewage seeping out the ceiling, that's a red flag straight away, I would say. There were very obvious red flags regarding the hygiene and cleanliness on this unit. And I think actually, if you just look at the tour of the building that is on my channel, it's not unique to my channel. That video's out there somewhere. Someone just gave it to me. You can see that it's dirty. It's not even like dirty on the microbial level. It's physically dirty externally. You can see external dirt. Like at one point, it's some out on the ceiling. So these are massive red flags, obviously.
Yeah.
I mean, I was mentioning to someone the other day. I know even the hand washing protocols have been questioned. I don't know how fair that is, but when I've been in a hospital, it's always been as a patient or a visitor, and I'm always so conscious of the fact I must wash my hands. I must wash my hands because if there's a germ that gets onto this unit, it's calamitous for adults, let alone neonates.
Yeah.
So that's my view.
Yeah.
What do you have to say about this?
We see you and I have got a distinct disadvantage, and we've never been into that unit, but we can glean a little bit from the information that has come out, and I think it was the parents of the triplets, I think, that gave some useful information on this front, because of course they experienced both sides of it. They experienced life at the Countess of Chester, and then they experienced life at Liverpool, and their testimony of it was fascinating. And they said it was like two different worlds. And they witnessed clinicians not washing hands between patients when they were at Chester, and they said the whole infection control side of things was markedly different at Liverpool, where they were really hot on things. So that's quite useful to know that. And of course, everybody's perspective on this has changed since COVID, because I think COVID taught us a lot of things, but I think it did teach us about the importance of hand hygiene and washing and using the gels and stuff, and being bare below the elbow, not wearing watches, taking rings off, and all that sort of stuff. And that goes right back to sort of Florence Nightingale days, really, doesn't it? So the answer to the first stem of that question is yes, there are defined protocols that are written in tablets of stone in any NHS trust about infection control and basic cleanliness, and you have infection control teams that go around the hospitals on a regular basis and check up on things. Most departments will have somebody who sort of heads up that. There will be defined cleaning protocols for each clinical environment, dependent on what they're used for. Different solutions that are bactericidal and virucidal that are used for cleaning. In a special care baby unit, there will be a protocol when a baby leaves the clinical area for that, for the incubator, all of the surfaces to be cleaned with virucidal and bactericidal stuff. So yeah, very, very tightly controlled. And of course, it's a critical part of any CQC inspection. Around there, justifiably really hot on it as far as infection control is concerned. And they spend their time looking at clinicians and nurses about hand hygiene between patients and things like that. So yeah, it should be right at the top of the importance, particularly in clinical environments where you're dealing with either immunocompromised patients or in the situation with neonate immunovulnerable patients. So you've got particularly premature babies that haven't yet developed their immune system, so they are incredibly prone to picking up infections, be they bacterial and viral. And for the viewers of this going out, Chris, this is just so they know when we recorded this. This has been recorded on the day after the Telegraph, and then I think today the Sun and the Mail have have put out an article which backs up something interestingly that I put out on X, I think 4 days ago, following the announcement of what's been uncovered at the Scottish flagship hospital in Glasgow, where there was this growing concern about the plumbing and water and sewage system in Glasgow, and that it was not up to scratch. And they cultured some bugs from it, which they've now got definitive evidence has harmed and killed patients. And I read this with interest, and of course, in usual fashion, it's been the trust has tried to keep it under the radar and cover it up, but now they're no longer in a position to do that. So the politicians are all over it, and apologies are being offered. And of course, that's a brand new hospital with a problem. But my eyes were out on stalks because the bugs that were shown to have been implicated in the harm to the patients. The first one that sprung to my mind was Pseudomonas, which of course was one of the bugs that was cultured in the Countess of Chester from the sewage that was backing up through the sinks and the plumbing system, and as you said, the nappies on the pipes. But there was also a bug which has got a name that's even more complicated than Pseudomonas aeruginosa, which is a pretty new bug. I'd never heard of it until it came up in the press conference about baby eye, which is it's got the name of Stenotrophomonas multifilia, which is a hugely complicated name of another bacterium. And this is found in sort of stagnant water and is commonly found in association with Pseudomonas. The difficulty with it is that it's very, very difficult to treat. It's antibiotic resistant. So, there's an irony about this, because if you think, we've been trying to work out why the only expert that was called for Lucy Letby's defence in the trial was a plumber. There's been, they were questioned, and it came out that it was a bizarre situation, that sewage was backing up into the sinks, and then what you said about the nappies being used for leaking pipes. But if you take a step back from this was a neonatal unit in the UK in the 21st century, and this was detected, and there was Pseudomonas at the time was known to have been in this fluid. The only appropriate action following that discovery would be to remove those vulnerable babies from that clinical environment. There was no alternative to my mind until you sorted it out. So you've sorted out the backing up, you sorted out the pipe work, and you sorted out the leaks, and you've liaised with your infection control microbiologist, and I presume it would have had to be referred centrally, and that you've got negative cultures that have come back. And then when you see in some of the rooms that, there's even a picture they may have been in the tour that you showed, Chris. There's a fan in one of the rooms, an old style fan. Well, they were sort of outlawed ages ago.
Right.
And you just think of the scenario that if you have got this stuff leaking out, you've got other things that couldn't be used, and then when presumably it was hot, you could have had these bugs in the environment, and then a fan that was blowing it between the cases. And I can't remember the specific timing, but I'm pretty sure there was about a 10-day gap between the unit knowing that there was this problem and this effluent fluid that was coming out was infected, and one of the indictment babies dying. Now, I'm not entirely. I thought all the while that this was such a profound problem for that unit that it was massively downplayed. And of course, what we don't know. Going back a bit, that new bug, the Stenotrophomonas, was cultured from the ET tube, so the breathing tube of baby eye. Now, I know it's contentious about whether that was the cause of death or not, and I think it was Michael, when he was interviewed, said that he didn't necessarily agree. You couldn't disagree that it was cultured, but I think he felt that it was hard to claim that was the cause of death, because I think they had negative cultures thus prior to the decompensation and the arrest of that baby. But it was there nonetheless. And of course, the other thing we don't know, but presumably somebody at the county justice will be able to answer this. Is it's not when you've got and let's not beat about the bush. When you've got human excrement coming out of sinks, that fluid is going to contain more than bacteria. It's going to contain potentially pathogenic viruses as well. So were they cultured? Did they do viral cultures on that fluid as well? Because there's all sorts of horrible viruses that can be, pretty horrible to adults, but certainly pretty horrible, even worse to neonates. And I do wonder when, maybe it will happen as a result of what's come out in the press yesterday and today, when more parents who went through that unit at the time of these indictments, when they read all this stuff, if they had problems with mums' infections after deliveries or babies that got infected, are they now going to come out of the woodwork? Because I read recently that there was a baby that was in the same clinical room as twins A and B, who developed prematurely, I think at 36 weeks or 34 weeks, who developed some sort of infective complication after the delivery, but was transferred out to Liverpool and then developed some pretty horrible, apparently, skin abscesses, which that's incredibly rare in a neonate. So what was all that about? What was the cause for that? What were the bugs that were cultured in that? So I can't help but think that the whole, it's been, I think, trivialized in a way, bizarrely trivialized. I mean, even Dowie Evans, I remember when Dowie Evans was interviewed by John Sweeney in his podcast, his face was aghast when I think it may even have been the first episode of that, The Hospital Full of Shit, I think he called it. And Dowie Evans apparently said he knew nothing about the sewage problems.
Well, he didn't look.
His response, even he said, "Oh, if it had been his unit,
yeah, it's one of probably pretty much the only accurate thing that he said. So I think now we know more about that. It's clear that there was some effort to keep this quiet because it's not in the RCPCH report, as far as I recall. But also, we should say that Dr. Evans didn't make any effort to look for anything. So he said, I don't want to see the report. I don't want to know anything about the hospital. I don't want to know anything about infection. I don't want to know anything about maternity. I don't want to speak to any other experts. So why would he know about it?
But even that comment alone, Chris, just hypothesize that had a bigger issue been made of that in the court case. And Dowie Evans had have made that comment of, if it'd been my units, I would have insisted it would have been closed down. Well, that would have been profound. It would have been jaw-dropping.
Yeah, absolutely.
And I can't remember the guy. Was it David Livermore? You interviewed the microbiologist. His stance on it was interesting because the anti-Letby lot will be jumping on this, of course, and saying, "Oh, yeah, but none of the babies were infected." Well, that's nonsense. And David made some comment about, yeah, but the cultures don't tell you everything because sometimes a baby can have infection and the cultures can be negative, particularly when babies are on antibiotics because that queers the culture. And I was thinking the other day about, do I know how many of the indictment babies were on antibiotics? I get the feeling that a very high proportion of them were, and that would also go some way if there were bugs in that unit that were maybe not the primary cause, but maybe they contributed to the babies having problems.
Yeah.
If they were viruses or so, I don't know. I think there are some huge questions that still need to be asked on that front. But the basic answer to that question is yes. There are defined strict protocols about infection control, which were heightened, and COVID was after all of this, wasn't it? But
yes,
they've been heightened since COVID. And if you in any area of medicine, if you fail on the basics, and I would put infection control as one of the very basics, hand hygiene, cleaning when you've a clinical environment when one patient needs it before the next one comes, you're going to have cross transmission of infection without a doubt, which is huge.
Yes. Okay, so let's talk about Apgars. So we were discussing this the other day, not when we're not being recorded. So let's discuss them here. So the question is, why did so many babies have adequate Apgars at birth, but yet soon afterwards showed signs of distress? Please, why do you think the prosecution stressed the Apgars? and yet played down the fact that many of these babies soon had issues. So I'll just mention that Apgar is this measurement that's done early on in a baby's life. It was developed quite a long time ago in the 1950s, and it's an acronym, and it means appearance, pulse, grimace, activity, respiration. That's how the name Apgar is derived. But the question is, why were these so much stressed when they really only deal with the first few minutes of life? And what other comments do you kind of have about this?
Yeah, I mean, again, for the people that aren't in the know, the non-medical people watching this, they were introduced by an anaesthetist in the 1950s. And they were pretty much accepted. It's one of the few things in medicine that was accepted pretty much across the globe, really. And they were very useful because in most areas of medicine, as a doctor, as a clinician, you want something sort of objective that you can judge something by. So, like like a blood pressure as a figure, something that is quantifiable. And the Apgars gave us that about a baby's condition at birth. So babies are scored, and they are done. That scoring is done. So the baby's delivered. You should then either look at the clock or start a stopwatch. And then the Apgar scores are calculated at intervals after that. And normally it's 1, 5, and 10 minutes. And then they're noted. So, and that sticks with you for the rest of your life. So in all the baby records, everything that goes out to the GP, it will be, Oliver Smith was born on such and such a date, weighing such and such, is a male, and the gestation, and on that the baby's growth is then charted, and the Apgars were 8, 9, and 9. So those figures give you, and I think this was a clever ploy by the prosecution, which worked because, of course, the evidence that they were presenting wasn't opposed by anybody, because the defense never had an expert. But for the lay people sitting in the jury, they're going to think, well, hold on, these scores are all okay. That means the babies were well. But that I think was a clever ploy by the prosecution barrister, because those of us that work in the clinical environment will know that the Apgars are pretty crude. I mean, they're a useful reflection of how a baby is at the time it was born. And you get most information, most prognostic indication about how that baby is going to do longer term at both extremes of the scale. So when the scoring is worked out, what you want is a baby with Apgars of 9, 9, and 9, and that's an incredibly good prognosticator for how the baby's going to do. The flip end of the scale, if you've got very low Apgars, so the lowest it could be is 0. But if you've got Apgars in the critically low range of 0, 1, 2, or 3, then it's likely that baby's going to need resuscitative input. And with those, you're more likely to get a baby that isn't going to do so well long term. But there's kind of a big grey area in between. But as the jury, if the babies were delivered and had reasonably good Apgars, then they're probably, the baby, this backs up Dr. Evans's theory that the babies were fit and well. But it doesn't tell you what happens after that. So you can have a premature baby that is born and goes on to develop crashing respiratory distress syndrome, but the baby may be delivered in very good nick. So it's going to have reasonably good Apgars, and it could be very good Apgars. But then when the baby struggles to maintain its respiration, might then, after 15 minutes, 20 minutes, and then thereafter have real problems. The other thing that I've seen no record of, and again, it goes back to the review of the maternity notes, is the other thing as an obstetrician that is far more value to us and to the neonatologist, really, is what the baby's blood gases were at the time of delivery. So in any baby, it should, and I don't know what the policies were at the County of Chester, but I would say the vast majorities of these babies, bearing in mind most of them were premature or complicated, they should have all had what are called paired blood gas results taken when they were delivered. So you deliver the baby, somebody's working out the Apgar scores, the umbilical cord. We now, and again, a deficiency that was found at the Countess of Chester is that they were way behind in what's called delayed cord clamping. So there is a merit, even in an emergency situation, of getting as much blood out of the placenta into the baby before you clamp and cut that incredibly critical link between the placenta and the baby. They were deficient in their years behind the cancer suggester in that regard. So the clinician who's doing the delivery, be it midwife or obstetrician or sometimes both, once that is done, so you cut and clamp the cord, you have a clamp on the baby, and baby goes over to the neonatologist at the resuscitation, leaving you with the other clamped end, the cord and the placenta. You should then have two heparinized syringes, and you take a sample out of one of the umbilical arteries, and you take a sample out of the umbilical vein. So what that does is it gives you paired samples, so you know the acid base status. So this is the oxygenation of the blood going from the baby to the placenta, but also from the placenta back to the baby. And the combination of the two of those is very, very good at telling you the condition that the baby was delivered in. I'll give you an example of how this could give you a load of information, Chris. With babies A and B, so the twins, so the mum, complicated mum, had a stroke at 26. And the more I looked into that case, you think, well, hold on, okay, so it seemed to be a semi-elective decision to deliver those babies. And she had a general anaesthetic, but then baby A came out asystolic, so it didn't have a heart rate. So that in itself is fairly alarming. So that means you've delivered the baby and it hasn't got a heart rate. So that's back to your Apgars. So, you know, what were that baby's Apgars? It's hard to believe that baby's Apgars were in the reassuring range. But even more interestingly than that, I would love to know what that baby's delivery blood gases were, because that would show, was it an acute, what was it?
Isn't part of the Apgars like the pulse?
It is, yeah.
So yeah. I mean, fundamentally, it has no pulse. So
well, it would have scored 0 on that. And if you've got no circulation, then you're not gonna grimace when you're stimulated. You're gonna get 0 for respiration, and you're not going to be active. So probably that baby's initial 1 minute Apgar was probably 1 or 0. But you get far more information about, okay, was this something related to the anaesthetic procedure that this baby couldn't handle and made it compromised at birth, or was it something that had been going on for a long while? These blood gases would give you that answer, because it tells you whether, is this something that's acute, it's just happened? Is it something that's been chronic, it's been going on for weeks, or is it something in between? So I think it's a red herring in the context of looking at these cases, Chris. I can see why the prosecution made a big deal of it, because they were trying to impress the jurors who were non-medical. So, you know, we've got this scoring system for the baby. Look, all these babies have brilliant Apgars. I don't think they would have done, but so I can see why the big thing of it. As far as what we're interested in now and looking towards an appeal and getting as much information about these babies as we can, I don't think focusing on those is going to be very relevant. The core gases, though, if they were done, because that's, I mean, done a bit of medical legal work and a review of an obstetric unit in my career, you tend to find if a unit's struggling, that the very basics of care get missed out. And this is one of them, that, you know, you would never ever be criticised as a midwife or an obstetrician for doing delivery cord blood gases, but it's amazing having looked at complicated cases and cases that have bad outcomes, and you think, well, the gases, oh, they weren't done. So you normally find in a unit that is struggling or not doing very well or hasn't got high standards, that the very basics of care, including cord gases, won't have been done. And I wouldn't be at all surprised if in this situation they weren't done. It's a bit like the triplets cesarean section. Each of those babies should have had cord gases done, but did they?
Yeah, and one thing I just should add is that I don't think it's true that all of the babies had good Apgar scores. From what I've been able to ascertain, they just mentioned them, you know, when it supported their case, and then didn't mention them when it didn't. Of course, you have to beg, borrow, and steal to get the court transcripts. You've got to piece things together. But from what I've seen, they just didn't bring up the Apgar scores when, you know, it didn't support their case. And I think the problem is the defence is operating without medical expert guidance. So they I don't think really said, look, the Apgar score for this baby was 0 or 1 or whatever it may be. If
Yeah, and
you,
of course, all the while they've got to try and support Dowie Evans's narrative that all of these babies were doing really well, they were stable. Which, interestingly, in his which we didn't comment on earlier on, but I did snigger as I carefully read every line of his statement that was put out in response to the CPS judgment, because he's not particularly careful in what he says or writes, is he? But I think actually for once with writing that, he was careful, because now he's got no responsibility over these new cases. All of the, and there's comment in there about if I got it up here, actually, it's all that the infants involved were unwell and very unstable. I mean, that's been very deliberately worded, hasn't it, to contradict what he said about the babies that he was responsible for looking after, which got through the CPS.
but now he has to defend that in the Court of Appeal. I mean, you would have to have done that anyway, but now he has to stand in the Court of Appeal and try to say these babies were all fine.
Yeah, yeah.
I don't
When
see.
he's going to be up against potentially four highest rated obstetricians in the country, you're saying, well, actually, so they weren't.
Yeah, and of course, I mean, I've already covered that letter on this channel. I mean, he said things there that you have to. I can't prove they're definitely untrue, but they're very strongly it points to them being untrue. Because he said, "Oh, I don't know anything about the specific cases. I'm not surprised that these have been overturned." Blah blah blah. But all you've been doing previously is telling us how I think Lucy Letby's put the babies in harm. I think she's going to be prosecuted for this. I think the third insulin case is that. So he's just full of it.
But it was
Just
only,
full
you've
of it.
probably got a better memory than I have, Chris. Is it November time that it was all in the papers that was it case 17 or something that he'd forwarded to the
Yeah,
CPS?
yeah, you're right. But I mean, I think wasn't that for child Q? I think it was for child Q where he started. He had said, "Oh, I think Lucy Letby might have removed the tube, didn't he?" I'm pretty sure that's what he wrote in this fantastic submission to the police. And then he said in this letter, "Oh, of course, tubes can fall out for a variety of reasons." So he's contradicted himself on that. That's what I mean about
Yeah,
the documentary. At this stage, there is nothing he can say that he hasn't said the opposite for previously, other than his name and the fact that Lucy Letby was convicted. He's just an absolute bullshit artist. It's as simple as that. And it's becoming more obvious the more he says that he's just willing to say anything. There's nothing he's not willing to do or say, except the one thing he's not willing to do is be interviewed by someone who actually understands the case. He's not willing to do that. He'll go on with a weak interviewer on Netflix who can't challenge him. But I mean, I suppose the one blunder he made was when he was interviewed by John Sweeney because
yeah.
he wasn't a weak interviewer, and of course that went catastrophically for him. And obviously he's learned his lesson from that. But
I
he,
think John Sweeney had the benefit of the primacy aspect of it, didn't he? He was the first one in, wasn't he? He was the
mm,
first journalist of any repute, really, that got in really early.
mm.
So yeah, astonishing. I imagine the police, well, assuming the police haven't been given the opportunity to look at this before he goes, I'd imagine they'll be a bit nervous about Dowie Evans's contribution to the Netflix.
Well, yeah, yeah. I mean, it hardly matters at this point because it's completely discredited anyway. So, but I think I think they will be nervous, but then again, they should be nervous about their own contribution. So they should worry about themselves because they had complete control over the video they put out on YouTube, and they still said all manner of stupid things. So they will get a soft interview from Netflix, no doubt, but they're still very capable of saying stupid things. So obviously I'll be watching like a hawk to see what they say. We'll have to wait and see. Well, I'm sure they'll drop a clanger at some point. They usually do. Um, let's talk lastly then about child D. So I'll read this question out, and then I have a couple of things to say, and then I'll ask for Martyn's opinion. So, dear Dr. Pitman, it seems to me that baby D's issues started well before Lucy ever met her. Is it possible for the parents to pursue legal action over obstetric failures, even with Lucy's conviction? So the first thing I'd say about that is that neither Martyn and I are lawyers. I've discussed this with a solicitor previously. Probably the answer will be on the channel before This is published, so you'll probably have been able to see that already. What I can say is that it's certainly been highlighted to me very strongly by, particularly by one nurse who I know, that child D's parents have very strong claim for legal action. At this point in time, considering that there's a court case outstanding, now they're doing the coronial process. Who knows what's going to happen with that? There's all these things. There's so much baggage at this stage. I think it would be very difficult for them to pursue legal action at this point in time because these things aren't resolved yet. I think when the fallout happens, I don't know where the parents would stand legally because it will have been quite a significant period of time since this occurred. But with that being said, I think any lawyer would say to them immediately, or any solicitor would say to them immediately, well, come on, there's very good reasons why my client didn't pursue legal action. The reason my client didn't pursue legal action was because my client was told that their baby had been murdered. So I think under those circumstances, it would be hard to just hand wave it away. But then the NHS is a powerful system, and Martyn knows that better than most. So it's very difficult to predict what would happen. What I can
Yeah.
say is that at this point in time, they can't pursue legal action, but ultimately they would have a very good claim, and I'm pretty sure solicitors were already involved in this infant, so that
Well,
they should.
certainly the trusts one was
Yeah,
because there's documentation that I've seen, so it's in the public domain,
right.
where following this case they sought involvement from any NHS trust is going to have either an in-house solicitor or one in a local legal firm that they refer to. And that certainly happened in this case, and then it came back that as one would expect, and we'll go into the rationale behind this in a minute, that the mismanagement of this case was indefensible, and that's in there in black and white. So let's just assume that the Letby situation hadn't have developed, and that poor couple had been managed as they were managed, and without a shadow of a doubt, if they'd wanted to, then the trust should have given them all they needed to do to go to a local solicitor and to put in a medical legal claim. And I have no doubt if that happened, given the negligent deficiencies in the management of the mother, which it's impossible to argue didn't at least predispose to what happened to the baby, if not sounds absolutely dreadful. And I used to hate chatting to parents in this regard. If your baby dies, then the amount of compensation that you get is derisory. Only talking about probably tens of thousands of pounds. So even if it was a bond or clinical negligence, the cases that hit the front of the tabloid newspapers and the multi-million pound, sometimes 20 million pound plus cases, are cases of maternity negligence where a baby was damaged through negligent mismanagement but survives and ends up with profound hypoxia-related disability, cerebral palsy, because then you're paying for lifelong care and accommodation and nursing input for the baby's life. So that's when you get the mega bucks payments. So the clinical deficiencies in this case are profound, and probably out of all of the cases, they are the most sort of jaw-dropping. I can't believe that happened. What basically happened, to simplify things, is the normal situation for a mother in late pregnancy before she goes into labour is contractions start, the neck of the womb, the cervix starts to dilate, and then the waters break. So the sac of fluid around the baby breaks and it lets out amniotic fluid. But that can happen the other way around, and that's what happened with this mother, in that she got through to term in the pregnancy, was almost undoubtedly gone out and bought loads of stuff for the baby, packed her bagging, ready, gone to antenatal classes. So a really exciting period when you're getting all optimistic and excited about what's about to happen, and apprehensive. But what happened with her is her waters broke, and that wasn't debatable. It was confirmed. So waters broke, but she didn't go into labour. Now, the membranes perform the waters perform, or the membranes around the waters perform two functions. They keep the fluid in, which is critical for the baby's development, which we discussed earlier on. But equally importantly, they act as a very effective infection barrier. So it's very, very rare to get an infection that comes up through the vagina to get into the uterus with intact membranes. Not impossible, but it's very rare. So from the maternity perspective, midwifery obstetrics, as soon as you've got confirmation that the waters are broken at any gestation, then the clock starts and the calendar starts. And most units with a term baby will have a policy that they will have a defined cut-off of time. And if the mother hasn't gone into labour by that time, they will do two things. They will commence antibiotics, and most units is the national guidelines are 24 hours. And you will recommend, encourage to induce, so to get the labour going, assuming that there are no, it's not the third pregnancy and the mum's had two previous cesarean sections, in which case you would recommend a cesarean. But in a first-time mum, once you've hit 24 hours, you would say, well, okay, we think we should induce you, and we'll give you some antibiotics. And most units will give intravenous antibiotics in labour. Now that didn't happen with this mum. So they confirmed the waters are broken. The other thing you should do as well is you should take a swab, again, very top at the moment, take a swab, a vaginal swab, in which will be the Lycor, and you send that off to the microbiology lab. And you do that because you will sometimes pick up pathogenic bacterium in that up the stakes. And the one you think about is group B strep. So that goes off to the lab and you'll get a result on that back in 48 hours. So this lady's waters broke, and not only did she go beyond 24 hours, but she went, I think it was 60 hours, 60 hours. And then I think from memory, she then ended up having a cesarean section for, I think it was failure to progress, so the cervix didn't open and the baby was delivered. Now you would have thought, and again, I don't know what happened, but at some point in time, there must surely have been some realization, be it from the maternity side or the neonatal side. It should, in theatre, or even before we went to theatre, there should have been a discussion between the midwives and the obstetricians and the paediatricians to say, Mrs. Jones is going into theatre for a cesarean section. For failure to progress, there's no immediate concern about the baby if there wasn't, or we were a bit concerned about the heart rate trace. Oh, and by the way, her waters are broken 60 hours ago. Oh, and we haven't given antibiotics. In an ideal situation, you say, well, the waters are broken and she's been on intravenous antibiotics, which should have been the optimal management. But that didn't happen. So it makes me wonder if that level of discussion didn't happen, because the baby was given, I think, to the dad, and then it wasn't for about 4 hours when I think the parent raised concerns about the baby not being very active and not responding, that the neonatologist got called, and they then took the baby and gave the baby antibiotics. So not only was it exposed to a potential infection risk for 60 hours after the waters broke, but they didn't even jump on the baby when the baby was delivered to give it antibiotics then, by which time the bugs clearly got into the baby and had caused the damage. And then that baby ended up with a pretty profound bilateral congenital pneumonia. And there's X-ray evidence that both of the lungs were white out from infection. And so again, it's another smoking gun thing that any logical clinician is going to look at what happened to that baby and say, well, that baby decompensated and had a from the pneumonia. But oh no, not in Dr. Evans's book. No, that was far too obvious. The baby was hit by another malfeasant cause of death. So that, just to put it in perspective, Chris, if I was examining a fourth year medical student, if they were in a sort of a pass-fail to get through their obs and gynae assessment, I would use a scenario like this. And if they had have made that error, bearing in mind the consequences of that. So as far as a medical legal claim is concerned, you've got to have a bad outcome. and then you've got to have an etiology for the bad outcome and a causation. So in the medical student situation, I would use this scenario as a sort of a pass-fail in a viva, and if they took prompting and didn't realise that prolonged rupture of membranes is an infection risk, and if it wasn't inappropriate, negligent to not give intrapartum antibiotics, and then after that would be, I'll come back when the leaves have changed colour, then you can sit the exam again. So this is basic, fundamental maternity practice, and a completely avoidable tragedy and loss of a term baby, which is just awful. The legal side of it's fascinating though, because one of my many concerns about where this is going to go is if you think the number of highly paid barristers that are involved representing the parents of these cases. Now, of course, they're criminal barristers, so they are going to be, and most of them will be looking after their clients, I presume, on a no-win, no-fee basis. So they will be set to earn millions potentially from these cases. The ones that presented at Thirlwall inquiry. Now, if Lucy Letby ends up getting exonerated, now although that doesn't necessarily prove innocence, from the perspective over these cases, it then potentially transfer these cases from a compensation for murder into clinical negligence claims. And of course, the importance of that from the barristerial position is you are going to have a lot of really hacked off criminal barristers that are going to have spent hours and hours and hours and hours on a no-win, no-fee basis, and they will lose these clients who will then go to their mates down their corridors, if they're working in chambers, who specialise in medical negligence claims. So that's going to be fascinating. That's going to be fascinating. And the thing you said about there being a delay, I will find that there is a theoretical time limit for medical negligence claims, which of course, we're way past that.
You can't just go back 25 years and go,
there is,
sorry.
Yeah, but I think in this situation, Chris, where these parents have been told, we believe inappropriately that your baby was killed, if it turns out, as I sincerely hope it will, particularly with baby D, that all of the evidence to me suggests that this was a natural cause of death, a pneumonia. And let's face it, when Jane McPartland, I think the pathologist who was pushed pretty hard in the Thirlwall inquiry, and she refused to budge on her pathological evidence about this case. She said, no, every single pathological sign that this baby died, and there's this big thing that's being made from the other side about from and with, did this baby die from pneumonia or did the baby die with pneumonia? The baby died from pneumonia.
Yeah, let me just repeat something that Professor Colin Morley told me. So Dr. Evans ruled out pneumonia, and Professor Colin Morley just told me there's just no conceivable way that he can do that.
No. You had X-ray evidence of it. There was a whiteout in both lungs. You had clinical evidence of it, and I think this was the case where there was evidence where they, and again, it's probably down to the lack of experience of the team looking after. I think they inappropriately reduced the ventilation on this baby, and then you've got histopathological evidence of a bilateral pneumonia as well. So I don't know what more you need to confirm pneumonia. And there's still people saying none of the indictment babies had evidence of infection. Well, I don't know what this is.
It's complete rubbish, isn't it?
It's complete garbage.
Yeah. So I think that's a good note to end things on.
It's depressing though.
Yeah, well, it is. I mean, the whole thing is horrible. It's extraordinary. I mean, that's why I made that video of 20 ways this debacle could have been prevented. There were so many chances to stop it from so many people, and they've all been incompetent or have acted in vested interest in some circumstances, we suspect. And that is depressing. I guess one of the most depressing thing is some of it doesn't surprise me. I guess the scale of failure is a little bit surprising. You would think one of those 20 opportunities, someone could have actually done the right thing.
Yeah.
But some aspects of it are not that, to be honest, the police investigation is not that surprising to me. For example,
Well, I know you responded that it's quite unusual for you to see you diving in and responding on social media, but I saw you responding to this police guy that put some posts out, and that was terrifying, really, because you've got a previous, by his own admission, a senior police officer who specialised in sounded like pretty top level.
Yeah, according to his biography, which
Think there was any.
I take that with a pinch of salt because it's social media, but let's just assume, for the sake of argument, that it's true. Then yeah, I mean, no, I don't usually respond. I don't even know why I did, but I mean, what was he saying to me? Oh, you don't know what a multidisciplinary investigation involves. I'm like, well, I know it involves more than one person. He didn't say much to that after that, but I just muted him 'cause he's just an idiot.
Yeah. No, I think going back to the point you just made, there were so many opportunities to turn it around. I think I mentioned this analogy before about the Swiss cheese model of clinical risk, and this case is the most profound, shocking example, I think, of the Swiss cheese model. And it's, you can imagine Swiss cheese with holes in it, and if something goes really seriously wrong in medicine, you're unlucky enough that you've got a big lump of Swiss cheese and all of the holes in it, which are individual errors, normally don't line up. So normally at some point you get into the cheese, but you don't go any further because somebody aborts it going any further. I think the Lucy Letby case is the classic example of she was unlucky enough that every single hole in that Swiss cheese lined up from one side to the other. And I rest one what I've always said. I think if any other neonatologist in the world had been appointed by the CPS or the police service to look at these cases initially, we wouldn't be having this discussion now, and Lucy Letby would probably be an advanced neonatal practitioner somewhere.
I share that opinion, and that's why when I was asked this question about who's the most responsible, I would always put Dr. Evans at the top of the list, even though other organisations must and other people must, take their share of responsibility. But I share your view completely. I think any competent doctor with a paediatric or neonatal would never have done what he did.
And this is just very early interventions that would have stopped it, or if the police had adhered to the NCA's recommendation of that panel, and if that had got appointed, then there is no way these cases would have even got to court.
Yeah.
Because Dowie Evans's ridiculous theories would have been, you can't be serious. Why are you missing a pneumonia in this baby? What are you?
Yeah, absolutely. And he knew that. Why else would he get rid of them? Why else would he say, "Oh, I don't think"?
Well, he didn't want his theories to be interrupted.
Absolutely.
Didn't want his fee to be diluted, did he?
Yeah. Well, that would be my presumption for sure. Because any responsible doctor would say, "Oh, of course we need to get other experts in. Of course we do." What kind of responsible doctor would say, "Let's not do that. I'll do all the reports. Then I'll handpick the experts for you. Then I'll show them my reports and tell them what to say." What kind of responsible doctor would do that?
Yeah,
they wouldn't. So, yeah. So, well, that's the situation we're in. That's what we'll have to deal with. Hopefully, we can resolve this and exonerate Lucy, and we'll just keep going. With that in mind, your assistance is very much appreciated. It's been another very illuminating session. We've got many questions left still from viewers, so there'll be more of these sessions in the future. I don't even know when this is going to be broadcast because I've interviewed so many people recently, and the Netflix thing's coming out. And we're doing more content.
Yeah.
I don't know when this will see the light of day, but.
And a big thank you and appreciation to the people that put comments as well, because it's very nice. Having done these interviews, that they are being well received and appreciated. So thank you for those.
Yes, I will echo that. So thank you, Martyn, and we'll talk again soon.